Hello?
I've had a chance to share some of their feelings, and I feel on this webinar, because for me, I'll expect questions which I will answer ably on the area of herbal research. So I think that's the kind of introduction I can make to you. Can also add on that I'm a board member, National Drug Authority, the longest serving board member, representing the docket of research in natural therapies. I'm also a teacher by profession. I've lectured in Makerere University and served as an external examiner in the School of Health Sciences, as faculty, the science faculty, veterinary school, again, always on the herbal side. So kindly feel free to engage me on anything herbal research, and I'll ably give information related to the current situation. That's what I can present to just usher you into what you can ask me. Thank you.
Thank you very much, Dr. Nambatya, for your presentation. We're now going to have, please, once again, take note of your questions as our panelists present, and remember to write them down or drop them directly in the chat box, and we will ask them in the Q&A. Now we're going to have Arnold Kabbale. I had already introduced Arnold, but once again, he is a pharmacist and drug formulation scientist and the proprietor of Crystal Pharmaceutical Limited. Arnold has also written interesting articles recently about the ongoing debates on treatment. And so thank you for joining us, Arnold, and please make your presentation.
Thank you very much, Haggai. I do not know if you can see my screen.
Let me check. Yes. Thank you very much. We can see it.
Yeah. So thank you very much. And thank you to the Chevening Alumni Association of Uganda. I am very, very humbled to be here. My name is Chemotherapeutics Kabbale. My middle name is Arnold. Most of my friends know me as Arnold. I am a pharmacist. I've done a few academic things here and there. And my research interest actually is in development of inhalable nanotechnologies and vaccines. So if you want to develop something that, instead of injecting people, they can inhale it, that's something that I can do. If you're interested in targeted drug delivery for cancer or for specific tissues and body organs, that is my area of interest. I did have a presentation which I will run through very quickly, just to set the trend on some of the common myths. So this will take about 5 minutes, but I'll be as fast as possible. Maybe what I forgot to say is that I'm also very humbled to be with Dr. Sabrina, who was my lecturer, and Dr. Grace, who is a board member of the NDA and a member of Rotary Club of Muyenga. So these are my seniors, so I'm their junior. In terms of this discussion, I thought I would just focus on some myths around vaccination because I believe Dr. Grace is better positioned to handle the natural medicine elements, and Sabrina, as a clinician, will be better at issues to do with adherence to SOPs and conventional medicine. However, I do write about this. I've been part of clinical guideline reviews, and I believe I have a very decent understanding of some of the aspects. Maybe just to set the stage, I want to also say that I believe in science. I believe in the ability of vaccines to avert health crises. I believe in the need for comprehensive data for decision-making, and also the authenticity of the process of clinical trials. I believe so much in this that I volunteered for the phase 1 clinical trials of the Oxford vaccine last year. You can see on the right of the screen, my name. I've hidden my date of birth and address because, okay, jokes later. Yes, then, and you can see I got the first shot on the 11th of May 2020, and I've been alive for more than 1 year. So you can rest assured that actually vaccines do not kill. I am still here, at least for now. So very quickly, some of the myths that we've had, that the COVID vaccines were developed very fast and therefore they are not safe. Just to set some context, the Moderna vaccine has been, the platform developed by Moderna has been undergoing research for more than 10 years. And the Chadoc's vaccine, which is the chimpanzee adenovirus Oxford 1 vehicle, has been undergoing development since 2014. So there's been a lot of time invested in developing vaccines. The trials can be accelerated when you have many patients and many volunteers. I was volunteer number 74, but I registered 1 minute after the portal for vaccination was opened. And within 5 minutes, they had closed the portal. So that is how fast people are volunteering. And lastly, there's been a shift in technology. Previously, vaccines used to be made by injecting eggs with the pathogen that you want to culture. And that takes a long time. That takes weeks to develop. But now with RNA technology, you can actually develop a vaccine for the people on this call in a few minutes, probably for the entire Uganda in a couple of hours. So that's how fast technology has moved. The next one is that the COVID vaccines are still test products and it has not been determined whether they are safe or not. So some of you are still waiting. Actually, if you look at the far right of our screen, here, where I have highlighted, you can see that all of the vaccines we are actually using are in phase 4, which means they've been through the preclinical process, the clinical trials process, they have gotten market authorization, and they have received post-market approval. Sorry, they are now undergoing post-market surveillance, which is we are monitoring them as they are in use. Number 3 is that vaccines do not work, as I still need to wear a mask and can get infected and can spread the virus. This is partially true, but you have to understand that vaccines are not personal protective equipment. They are not a physical barrier that stops you from coming into contact with the virus. What they do is they train your body to fight off an infection and to reduce the ability to transmit. And once this has been achieved, once we have a critical mass of people vaccinated, then you can remove your mask and you can resume normal life, as we have seen in the more developed world. There's another myth that says one vaccine is better than the other, and people tend to use this part that talks about infection. And we've said vaccines don't entirely protect you against infection. But as you go looking at the severity of outcomes, symptomatic disease, severe disease, and death, you realize that actually almost all vaccines protect you 100% from dying of COVID-19. So in effect, they are more or less the same, and you should not wait. If there is an opportunity to get vaccinated today. Myth number 5 is that the vaccines protect against earlier variants of the virus and will not protect you against the newer variants. So you have to keep getting new shots every day, every time a variant develops. That is not true. Looking at preliminary data, and I just got to Pfizer and AstraZeneca. When you look at the blue column, that is the alpha, which is the traditional strain, and then you look at the delta, which is now the strain that is causing us a lot, the variant causing us a lot more problems, you realize that in terms of infection, there's less protection against the Delta variant. But as you go up towards severe disease and death, they tend to normalize. Yes, we do not have enough data on death yet, but in terms of severe disease, you see that there is not much difference between the Alpha and Delta variants. And then the same thing for the AstraZeneca vaccine. Even if it's at a lower scale, you do see that there is decent protection. And so what that tells us hopefully is that even in terms of deaths, the current vaccines should give us a very high amount of protection. Then some people have said that vaccines can make men and women impotent. So far, there is no data about men complaining about impotence or reduced libido. What people who spread propaganda are saying is that the S protein, because we talk about the spike protein, we say it in short, S protein is the same as the syncytin protein that is used in attachment of the placenta in pregnant women. The truth is that they are different. And in the clinical trials, there were no people who reported severe challenges with conceiving. In fact, for the Pfizer vaccine, 23 volunteers became pregnant. Only one had a complication, but she was in the control group. She wasn't receiving the vaccine. Now, what may happen is that there may be distortions in your menstrual cycle, but from what I have been able to read so far, this will happen for maybe 1 or 2 cycles, and it doesn't happen in everyone. So people who still want to get pregnant can use the vaccine safely before they get pregnant. It is okay. I'm going to wrap up in the next 2 minutes. Number 7 is that people will put computer chips in us. The average size of a chip is 11 millimeters by 1 millimeter. Now, you can imagine that the bore of a syringe is 0.6 millimeters. So it is obvious that this cannot be injected in through a syringe, and it is not possible for them to inject it into you and you do not realize. People who take vaccines die soon after vaccination. That is not true. 2.6 billion doses have been administered as of yesterday, equaling to about 1 in 5 people in the world. And the number of deaths, so the places where we have good tracking of deaths after immunization, shows that only 1 in 50,000 people have died. And this is from whatever reason, including car accidents, suicide, you name it. So it's not necessarily related to the vaccination. What may happen is some people who have a symptomatic infection may have it flared by immunization because of the presence of adjuvants and some of those other ingredients that are meant to make the vaccine more potent. But these should still not cause death under ordinary circumstances. And it's very, very low. The likelihood of dying from COVID when you're unvaccinated is still higher. The vaccine will change my DNA. This is not true. The mRNA and DNA vaccines do not interact with your personal DNA. They just give instructions. Actually, on their own, you wouldn't even want to call them DNA. They are just carrying the instructions for development of DNA of certain proteins of the virus. So there's no way in which they interact with your nucleus and with your personal DNA. And lastly, vaccinated people are highly infectious. This is not true because none of the approved vaccines are live. All of them are dead or are just components of the vaccine. So on their own, they cannot spread disease. Thank you very much. I will end there. Over.
Okay. Thank you very much. Sorry about the technical glitch. I was trying to unmute myself and the technology was complicating things. So we'll now have, thank you very much once again, Arnold, for busting those myths. We are now going to have our next panelist present. Our next panelist is Dr. Sabrina Kitaka. You're welcome to make your presentation, Doctor. Dr. Sabrina.
So the host had muted me.
Sorry about that.
That's okay. Good morning, everyone. Morning, Haggai. And I want to thank the Chevening alumni for inviting me to talk to you about COVID-19 and possible treatments. Because I am a pediatrician, I'll bias my talk towards treating children because that's what I do on a day-to-day basis. So bear with me. We've already known that SARS-CoV-2 is a virus that causes coronavirus disease, and SARS simply means severe acute respiratory distress syndrome. It easily spreads from person to person, and because it's a novel coronavirus, there's very little immunity in human beings. So if you get infected, you may develop antibodies, but those antibodies are likely to wane off really quickly. As of yesterday, there were 180 billion people who had gotten COVID-19 worldwide, and there were 3.9 million people who had died. 180 million. So for me, this weekly update is what keeps shocking me, that in the past week, the number of new COVID cases and deaths continued to decrease, with over 2.6 million new cases and 72,000 new deaths. But the decline of the weekly numbers compared to the week were reported across all regions except for the African region. And I'm very glad that Dr. Kabbale presented about vaccines. There's a lot of hesitancy towards vaccines in Africa, but also there's very little vaccine in Africa. The number of new deaths reported in the past week decreased across all regions except the African region and the Southeast Asian region. Again, those are the places that have limited amount of vaccine. By yesterday evening, Uganda had confirmed 76,562 cases with 830 deaths. We are now getting approximately 50 people dying on a daily basis, and we condole with everyone. It's so painful to lose somebody close to you and somebody you know. So these are just the updates visually. And sadly, the concentration of this epidemic, the epicenter of it in Uganda is Kampala. And we've heard that there are various new variants of concern in the Kampala region. And so we are all really frightened because Kampala is the heartbeat of Uganda. The incubation period between the time of exposure and the time of onset of symptoms is typically 2 to 14 days. But it's very important for you to know when your first symptom happened, because that's going to determine your actual process of the disease. If you know that your first symptom happened on the 1st of June, please count 7 days. If nothing happens, then you're likely to be a mild case. But if you start getting high-grade fevers, difficulty in breathing, then that means you're in a cytokine storm and you're likely to go into the moderate or even severe type of COVID-19. So what can we do? What can we do? We should always be informed and prepared, but please get information from the right sources. Turning yourself into a Google doctor is not going to help you. And also turning yourself into a WhatsApp chat doctor is not going to help you anyway. Wear a mask, that has already been emphasized. And now we are even saying, if you're in a high volume, high risk space, wear 2 masks. And then washing hands, that has been told repeatedly. But if you're feeling sick, stay at home. There are people who will be sick, but they will insist on going to visit a friend or a relative. You are transmitting the virus. Now, recently children came back from school and people are asking, are children the super spreaders? Yes or no? It is very possible that children are super spreaders. because the majority of children have mild disease and they can actually spread the infection to adults. Information on COVID-19 is changing rapidly, sometimes daily, sometimes per minute, and the COVID-related lockdown has told untold suffering and multiple disruptions. COVID-19 is actually presenting like a VUCA situation. It is volatile, it is uncertain, it's quite complex, it's chaotic. Chaotic because there are new technologies which people don't understand, there are conspiracy theories, and then it's ambiguous. Ambiguous because of the information overload. And sometimes even we think that there's an infodemic, an overload of information that may be difficult to understand. COVID-19 has disrupted education, there's no doubt about that. 17 million children and adults and young adults are out of school. And you know that when children are not doing much, they are not in school, there's a lot of vulnerability that can happen. Children have become pregnant, children are becoming laborers, and you know, it's all very disturbing. So whereas many children are mildly sick, unfortunately, the ripple effects of COVID-19 are going to affect children more. Many of them may never go back to school, and their cycle will start as poverty and poverty and poverty. There are essential services disruptions. There's a disruption of care. I ran a general adolescent clinic at Mulago, and unfortunately during the lockdown, this is one of the first clinics that gets closed. So adolescents are not able to receive their vaccinations, they're not able to be counseled face-to-face, and it gets a little bit creepy. When you know that when people are relaxed and they don't have anything to do, they become idle, and idleness is a devil man's workshop. So there's a lot of physical violence and even interpersonal violence, but alcohol and drugs are becoming increasingly a problem. And people are going to become alcoholics during the lockdown, and managing a chronic alcoholic can be a complicated issue. We would like that every child grows up to reach their fullest potential. And for me, that is my purpose in life, to support every child to grow up and reach their fullest potential. School reopening started in March 2020. And then in March 2021, there was staggered reopening. And before the children were settled into school, schools were already closed. I had the opportunity to visit Gayaza High School to talk to them about promoting the SOPs. And the students had so many questions. But we all know that when there is one case in school, that's potentially the whole school becoming infected. And you all know what happened. Many, many students coming out of school were infected. There are considerations for virtual learning. Many of us are turning out our children into computer geeks. They're learning online, but we have to be careful as parents, as pediatricians, to monitor screen time, to encourage the students to take breaks and maintain physical activity, to ensure adequate oversight and supervision of what they are doing, that they are actually learning and not playing pro books or even watching things that are not for their age. And then it's important to maintain social interactions. We shouldn't turn our children into robots. So do you have children at home? Maybe many of you have children at home and you're worried. How do you identify COVID symptoms to help your children get prompt treatment? Our children have been at the receiving end during this second wave. And we've seen many children coming in to the hospital with complicated illness, but also we've had multiple phone calls of people whose children have suffered from COVID. So these are the symptoms. The majority of children will have mild symptoms: fever, cough, shortness of breath, fatigue, myalgia. They may lose their sense of taste, lose their sense of smell. I've seen a child who just presented with a hiccup. But other children may get the severe form of COVID-19, and that's a multi-system inflammatory syndrome. In the past 2 weeks, we've treated 2 children with this syndrome, and they both had COVID-19. One was a 9-year-old, and this week we had a 10-year-old who was critically ill and had to be admitted. I have treated a 17-year-old who had multiple comorbidities, sickle cell disease, chronic kidney failure, and she had respiratory problems. Unfortunately, we lost that 17-year-old. This is a rebreather mask, and the child needs oxygen. It's important that they get it. So these are some of the preventive measures: wearing a mask, hand sanitizer, talking to children about the importance of prevention, talking to them about not visiting their elderly grandparents or even their elderly parents. And when someone in the house has COVID-19, it's important for everyone to mask up. It's also important that if you're using a shared bathroom, please wear a mask when you go to the bathroom. One of the symptoms of COVID-19 is diarrhea and even vomiting. And we know that particulates of COVID-19 may stay in the toilet bowl. So if you're using a public toilet, please wear a mask, because as you flush, you may actually be splashing COVID-19 into your face. And yet we know we should avoid men. We should avoid the mouth, eyes, and nose. And if those particles land in those spaces, you can actually get infected. Following SOPs is so important. Wearing a mask to cover your nose and mouth. And this picture, this graphic demonstrates very clearly. If you're talking to somebody who's not wearing a mask, guess what? The moisture and the particles from the mouth will land on you. But if both people are wearing masks, that possibility decreases. These are the don'ts of not wearing a mask. Do not give it to children below the age of 2 years. Use a surgical mask or other PPE when you're a healthcare provider. I've seen, people walking on the street with surgical masks, yet actually people could wear 2 cloth masks or double cloth masks and actually stay safe. So when we take care of children, it's important for us to seek help. Seek help from a pediatrician or call the hospital. You can use a phone and call a doctor. Please do not self-medicate. People are taking buckets of antibiotics. People are taking loads and loads of corticosteroids, and then they're ending up in hospital with complications of diabetes and ending up in hospital with Cushingoid syndrome. So let us be careful when we are giving our children medicine without consulting. The home treatment that is recommended in our guidelines is paracetamol, vitamins, hydration, enough sleep, doing minimal exercise, but also avoiding self-medication. Obviously, there are key challenges for all children, which may be caused by COVID-19. And these are individual to programmatic, from national to regional, continental to global. But we can solve these challenges together. Dear parents, if you're a parent of an adolescent, talk to them about sex and sexuality. Do not let your children be deceived into doing things that are of high risk, because they could end up losing their entire career or future by becoming pregnant early or joining bad groups. So we need to keep talking to our children. I want to acknowledge my parent department, the Ministry of Health, but also the Chevening Alumni Executive Committee that has put together this amazing webinar, and we'll wait for questions in the meantime. Thank you so much.
Thank you very much, Dr. Sabrina, for that very informative presentation. I'll go straight into the questions now. Just a quick reminder to our participants, please just drop your questions in the Q&A section. Yeah, don't try to, I saw someone raise their hand. We are only taking questions in the Q&A questions, and that's to make life easy for everyone. So in terms of, thank you again, our panelists, for all the informative presentations you've made. We are talking treatment and prevention. Perhaps understanding how we got here may help in terms of understanding the prevention mechanisms. By March 2021, there was a sense that Uganda had defeated COVID. There were a few admitted patients. The cases had dropped tremendously, at least from the reports we were getting as lay people. How do we find ourselves in the situation we are currently in? The question goes to you, Dr. Sabrina.
Oh, thank you very much. So you see, COVID-19 never really left Uganda. And as long as people continued to think that COVID was a myth, they started to let their guard down. And the more they let their guard down, the more the COVID-19 spread. If you look at mathematical modeling, one individual who has COVID-19 is able to spread COVID-19 to 400 people within 4 weeks. So that individual can spread to 5 people, and those 5 people spreads to another 5 people, and the story goes on. So by the time the COVID-19 becomes very prevalent, then the 5% of the people who are extremely vulnerable, those who are critically, who have non-communicable diseases like hypertension, obesity, and diabetes and chronic kidney disease, they are the ones that will start to go to the hospital. Then the 15% who get moderate disease and need excessive oxygen requirements will also then get into the hospital. And those are the people who overwhelm the health system. And it becomes an avalanche of panic. And I think that is what happened in Uganda.
And there's also been debate, there's been debate about the severity of some of the variants we are seeing, and people attribute the high number of deaths we are seeing, at least in Uganda, to the coming of new variants. Is this the case? And if it's not, what explains the fact that we had COVID in 2019, very many cases, but we had very few deaths, but now have the deaths have skyrocketed? Again, to you, Dr. Sabrina.
So it is true that the virus has mutated from the original Wuhan virus of December 2019 to variants of concern. There is the Alpha variant, which was discovered in Kent in the United Kingdom, and then the Delta variant, which was first seen in India. But then there are also other variants. Even Uganda now has a variant of concern, but there's a variant from Nigeria, there's a variant from South Africa, and aeroplane movement didn't stop. And whereas people were tested before coming into the country, you can acquire COVID-19 on the plane, and then 2 days later, you actually unwell. So it's all very complicated. But from looking at data from the Virus Research Institute, it is true that the Delta B1167 is the most predominant one in the Kampala region. But also now we have the Delta Plus, which is another mutated variant. The COVID-19 virus is an RNA virus, which replicates extremely quickly. And whenever you find such a virus, you know that whenever it's replicating, it's going to make mistakes. And those mistakes are called mutations. And whenever a virus makes a mutation, then that mutation may be beneficial to it. The Delta variant is very transmissible, extremely transmissible, much more than the original virus that was found in Wuhan. And so this is what we are seeing now. There's also overcrowding, which happened. Many schools, whereas boarding schools, but people keep coming in and movements didn't stop. But also children were put in, taxis to go to school. And these children are spreaders, I could say. So you're in a taxi, someone is not wearing a mask, the child doesn't show any symptoms, they'll go into school. In fact, their teacher who has diabetes, that teacher has to be rushed to the hospital. So it's all that. But even in the hub of Kampala, the business center, the chikubos that we know about, people were not wearing masks. And so that was all a waiting time bomb. And now the bomb has exploded.
You as given your experience, attending to children as a pediatrician, what do you say about the deaths we see globally of children? I mean, in the past, in 2020, I happened to be in a household when I got COVID, where there were 2 kids, one 9, another one about 12. They didn't get any symptoms. In fact, they went on about their lives while everyone in the house was severely ill. Now, children are dying, kids are, getting severe symptoms. Is this down to the more severe variants? What may explain it?
So the truth is, children will get COVID-19 in almost equal amounts to adults. And for this Delta variant, because it's highly transmissible, it will spread. If one person in the house has COVID-19, even little babies of 3 months will get COVID-19. The good news is children tend to get milder symptoms. And all the papers I have read from Wuhan, from the UK, from the US, I've discussed with my colleagues in the US, children do not have a higher mortality rate. And this is the same thing we are seeing in Uganda. If they say that 49 people died yesterday, out of those 49, it is very possible that just maybe 2 of those people will be children. So the prevalence of mortality is much less in children. And the reason why children tend to get milder symptoms is because they have a very high T cell count. They are still outpouring lymphocytes, and they are probably having less comorbidities. So they will have milder symptoms. The other thing which has been theorized is that because children tend to suffer from multiple colds and flus, parainfluenza, coronaviruses, etc., that they may have antibodies that are protective of them. But also children run around, children are physically active. They're always playing in the sunshine. So their immune response is actually better. The children who get severe illness, and these will be very few, not many, are those who have had a huge load of infection. Maybe the parent had COVID, but kept wrapping around the child, or the child has a comorbidity with sickle cell disease or with chronic kidney failure, with cardiac failure. Those are the ones who we are seeing who are getting the bigger brunt of the disease.
Thank you very much, Dr. Sabrina, for those responses. I'm going to come to you, Kabbale. I think that's how you pronounce your name. Treatment. Is there any treatment for COVID-19? If so, who needs this treatment? Is it whoever tests positive or those who get severe symptoms?
Thank you. Just for clarity, will we be handling one question at a time, or should I write them down and then respond to them at once?
So in terms of the questions I ask you directly, respond to those. But if you feel that someone responded to questions and you also had things to contribute, feel free to go ahead. Like the questions I just asked Dr. Sabrina, you can also respond to them. There's no,
Okay, thank you. So the question is there any treatment for COVID-19 and who needs it? So there are many treatments undergoing clinical trials. One, they're looking at existing medicines and trying to see what can we repurpose. So people have studied extensively the path of the disease, and they've looked at different drugs, and they're looking for ways for drugs that may interfere with that process. So there are a number of drugs out there. One of the things I'm hesitant about is giving a prescription or giving my opinion, because people are going to run to pharmacies and buy drugs. We have a lot of people, giving opinions that are making prices go up. But then if you go to the hospital, there are national treatment guidelines. I may have reservations about them, but they're still the best source of treatment. There are different things. There are monoclonal antibodies. Basically, they can inject you with some passive immunity. So your body does not generate its own antibodies, but they give you either synthetic antibodies or antibodies harvested from other people to fight the infection. There are antiviral drugs that they're trying to check, and there are other drugs, and there are drugs that modulate the immune response. So, for example, it was alleged that chloroquine would, help to control the virus and control your immune response to prevent the cytokine storm that Dr. Sabrina spoke about. But what I would say, most people do not need, 80% of the people have mild infection. And you can take this, you can manage this by, symptomatic treatments, take paracetamol, take lots of fluids. It is only the people who are hospitalized that need treatment. These people who are hospitalized mainly because their oxygen saturation has fallen. So severity of disease is according to how much oxygen you have flowing in your blood, what percentage of your blood oxygen you have. And that needs a pulse oximeter. So if possible, it would be good to have a pulse oximeter. It's more important than a thermometer. And once you're in the hospital, they will manage your symptoms. Yes, that is trying to clear the congestion in the lungs, try to manage other infections that may come up. So for example, if you're intubated, there's a higher risk of getting a bacterial infection. If you're not intubated, there's lower risk. In terms of antibiotics, it is important to first get a culture, especially people who are in ICU. You see very high bills because they are doing a lot of testing. So they should be able to say, we're giving you an antibiotic because we have found you have a bacterial infection. Yes? But if they do that and there is no bacterial infection, it may not be necessary. That is just my opinion. Yeah, thank you.
Yes, thanks again. You talk about antibiotics. There's a raging debate on usage of antibiotics in treating COVID-19. And, a lot of pharmacies, I don't know if your pharmacy is one of them, are making a killing in this season, which is unfortunate for, of course, us, the consumers. And in fact, you've been a leading participant in this debate. You had an article run in Daily Monitor titled "Stop Irrational Use of Antibiotics to Treat COVID-19." I was reading up on the World Health Organization. Again, they make it very clear that antibiotics do not work against viruses, COVID, including the one that causes COVID-19. Tell us more about the usage of antibiotics and the dangers, and please feel free to mention some of the names that you won't be prescribing for anyone. Please, our participants, Dr. Kabbale, Kabbale is not going to prescribe. He's just giving us information. Don't hear a name of a medicine unless he decides to, make it clear that this is helpful. Don't go and buy these drugs. So back to you. Tell us more about the usage of antibiotics and the danger, if there is any.
Yes, thank you very much. So what I have seen, of course, the most common one is azithromycin, which basically actually does not kill bacteria. What it does is it stops protein manufacturing in bacteria. And hopefully your immune system can then come and engulf the bacteria and dispose of it. And this is one of the most selling drugs. I've seen a lot of people on social media saying, I beat COVID-19 and this is what I used. And firstly, we need to go back to those people who say they beat COVID-19 and say, were you in the severely ill group or were you in the mild to moderate group? Because if you were severely ill and you were on oxygen, then that is actually where our key concern is, because that is the group that is likely to die. If you're not on oxygen, you're at home, you're running, you're going jogging, you're not at risk of death. So we need to interrogate that. Now, azithromycin does not work against viruses. Yes, so we do not need it. The second one is amoxicillin, which is a class called the beta-lactams. These bacteria, these antibiotics, amoxicillin, the penicillins, and so on and so forth, what they do is they break the cell wall of bacteria. Yes, so if you have, there are bacteria that will have a cell wall and there are those that will not. But those that have a cell wall, the antibiotics break that cell wall. Now that cell wall is different in viruses. Does that make sense? Is that a simple explanation? So I cannot come and I say I want to treat people. My treatment only works if it's administered on the left arm. But if you don't have a left arm, I will still give it to you. Then the third one that's really going around is ivermectin, which is really used for managing helminthes and worms and that kind of thing. And it's more commonly used in animals and then in a few what we call neglected tropical diseases. It is also not necessary. WHO has shown has stated that it doesn't work. But as scientists, where do we get our information from? We look at what are called clinical trials. We also look at what are called meta-analysis and systematic reviews. Basically, this means that people get hundreds of papers of research studies of people who have tried to test something. They filter out those that meet the minimum standard of being a credible research paper, and then they compare the results. And in all of these, the results have shown that ivermectin, amoxicillin, azithromycin, they do not work. If you spend your money on that, that is not likely to be money well spent. I do understand that people are worried and they're like, whatever we can, whatever might help, let's try it. But the danger, I've seen prescriptions that have 15 drugs. When you have so many of these drugs, you're going to overwhelm your liver, you're going to overwhelm your kidneys. And remember, because when you have COVID that has disseminated, it's not only in the lungs, it's doing damage to your liver, it's doing damage to your kidneys, it's doing damage to every organ in your body, your pancreas, you name it. Once you now add additional stress of clearing all of these excess antibiotics out of your body, you might actually accelerate multiple organ failure. Yeah, thank you.
Thank you very much. There are other drugs that people have or that pharmacies have been giving out, and I also wanted to talk a bit about them. One of them is dexamethasone, something like that. I have read in a medical journal that it should be used for those on using ventilators. The people also use zinc, vitamin D. What about these? Are they you know, are they treatments people should be using, or again, there's myths around them?
Okay, thank you. I was just capturing that. Just give me a second to. Okay, yes, thank you very much. So dexamethasone is what is called a corticosteroid. What corticosteroids do in our body is that they reduce the activity of the immune system. So remember, we've said that the complications of COVID-19, the mucus production in the lungs, that is the immune system panicking. It's trying to respond to a foreign body and it doesn't know what to do. So it says, let me pour a lot of liquid to try and wash out the lungs, right? So what dexamethasone is meant to do is to reduce that panicky response. Yes. So now, in people who are not in severe distress, who are not hospitalized, of what purpose is it? Because your lungs are not congested, your immune system is doing just fine. It's not overreacting. So you do not need it there. But for people who are hospitalized with severe disease, it may offer benefit. A study by the University of Oxford last year showed that it works. But also on this point, I want to commend Ugandan physicians. We have a lot of experience with HIV, and we had PCP, pneumonia carinii pneumonia, or pneumonia girovechi. I don't know what the current name is, but it used to kill a lot of people when they had, when their immune system would go down and they would get this. And we used to use corticosteroids in high doses, well, in tapered doses, and it worked. So I think there is benefit of dexamethasone in hospitalized patients. But this has to be overseen by a medical doctor, because you don't just start taking. I've seen on social media people saying, take 2 times 2. What does 2 times 2 mean? How many milligrams are in a tablet? So what happens is that there's a way in which doctors recommend that you phase it in, you scale it up to the maximum dose, and you phase it out. And that is what you want to have. You want to have a doctor present. Now, what are the disadvantages of dexamethasone? One, it reduces your immune system response. So it means it exposes you to other infections. Does that make sense? I want to strongly believe that what we are seeing in India with what they call the black fungus, because fungal infections are generally opportunistic infections, these people are using a lot of steroids and they are not maintaining a clean environment. So they reduce their immune response, but they're still exposed to all sorts of pathogens. So that is why I would only recommend dexamethasone in an ICU where they're able to maintain sterile conditions or close to sterile conditions. And there has to be a doctor and an ICU nurse to supervise and to monitor you. So that for me is the main thing. Suppressing your immune system, other infections will take advantage of that. In ICU, when you're intubated, remember, the tubes they've put in your nose will give you additional exposure to pathogens. So that is why you have to be extremely careful. It has to be supervised by a doctor. A pharmacist should not prescribe it, because by law, pharmacists do not prescribe. Yeah. What happens is that a doctor should write a recommendation. As a drug expert, I look through the recommendation, not to challenge the doctor, but just to make sure that we have done due diligence, that the product being given is best for the patient. Vitamin C, vitamin D, and zinc. So vitamin C, I will talk about vitamin C. I won't talk about vitamin D or zinc because I have not read very much about them, but also if possible, maybe somebody else can step in. Very quickly, people who have these diseases, like these conditions, like diabetes and hypertension, when you look at the amount of vitamin C in their body, or ascorbate, that's the more scientific term, it is very low. People who are in distress in ICU, normally they have very low levels of vitamin C. Yes, so that is one thing. So giving people vitamin C may help to restore the normal balance. Why is vitamin C important? Now, I'm not saying it treats COVID-19 because the data does not show that, but what data shows is that vitamin C has a protective effect in encouraging your neutrophils, what are called neutrophils, to be activated and to begin looking for the free-flowing bacteria. Vitamin C also helps in modulating your immune response, so the production of mucus in the lungs, that inflammation. So it has benefit there. But in terms of clinical trials, there is not enough evidence to recommend it. So I cannot recommend it, I cannot discourage it. If you use it, at least it is not likely to be toxic. About vitamin D and zinc, I will probably leave that to other people, but I am not sure of the clinical benefit. Actually, for zinc, there are studies that show that it does not have much benefit, but it might have other uses on why it is being prescribed. Thank you.
Thank you very much. Dr. Grace, would you like to jump in and share your views on the kinds of treatments that you know have been going around?
Thank you so much. Probably let me link in here on vitamin D because I've read a lot about it, and it's also on the guideline for Ministry of Health, where they are recommending 50,000 international units. I would just say vitamin D3, especially D3, it's prompted by the sun reacting with some precursor cholesterol under the skin, forming this D3. But when you read about it, it's like it supports the harmony of most biochemical reactions in the body, in a sense that if you have very low levels, then even if you're given medication for anything, you find that you're not responding very well. As people age, these low levels of D3 make them, like people who have, say, diabetes, hypertension, the diabetes really just gets worse because of low levels of D3. So under COVID, D3 has come so much into the limelight in the developed world, to the level that it's almost a must supplementation for age 50 and above, given its protective role. So I would like to encourage Ugandans to read around. Let's know more about it, because it seems to have a very great attribute, especially towards prevention of or succumbing a lot to COVID-19. We've read about our fellow Black people in the diaspora, where the sun is not strong and they don't supplement. Probably many are in busy in odd jobs. They don't really get into the mainstream of supplementation, and there's a lot of linkage there we need really to know. And I took this as important when I saw it put on the guideline for community management of COVID-19 by Ministry of Health. But it's important to first check through a physician, to first check the levels, so that you're guided by a prescriber, because you'll find 2,000 international units, 3,000, 4,000. It's important to take the right amount, and also it's important to know that we may also have a lot of fake D3 on the market, so the source would matter a lot. And the guideline goes on to tell us about the food sources for D3, mushrooms, these mukene, spinach, now that I've talked about that, we should endeavor to look at the guideline and pick out those, especially mentioned by the ministry, oils like from Mputa fish oil. I grew up seeing parents giving children cod liver oil. Now I understand there is some D3 in there. But now going on to comment on like use of herbal, there is a myth of thinking that all herbs are safe. You know, people really underrate herbs, but herbs can be very unsafe. Herbs can kill. There are those herbs, especially those we are investigating for, you know, effects on COVID. I'll mention one that is popular. It's called Wabugia ugandensis. I think it's also an ingredient in the trending herbal called Covidex. Much as that herb is very, very useful to the level of having effectiveness on tuberculosis, it has effects on malaria, and we are studying it for, you know, effects against COVID. It's a herb which can kill if you just take a dose that shouldn't really. For example, you need if you talk of prescription, it should be a prescription herb. So the challenges there are like if people publicize something and it hasn't been well guided, the fakers are there. They will simply fake the same thing and put a wrong dose, and before you know, there would be a problem. Some of these herbs are formulated as nasal drops, and people affected with COVID have high inflammation. So if you really reach out to a patient, some of us meet those patients and they describe to you what some of those herbs can do to them. Like if something is an irritant, it has a peppery thingy, like that one I'm talking about is like caramel, and then you have to drop it in a patient's nose. The patient can just faint depending on the age. So I have what I have to say. Yes, herbs are useful, but Uganda has not been focusing a lot on scientific validation. And now we have an avalanche of information. Still, it remains that there should be regulation, there should be optimization to know what is really, what dose is important. Because short of that, we would just get, you know, bad effects. But I'm glad to say that currently in this pandemic, there are things that have happened that will really take us to a higher level in herbal medicine. We didn't have a legal framework. There is now an act on traditional and complementary medicine, and that act means a lot. That act means there would be a professional council, which council would have on board like a dean of like a particular medical school, dean of clinical services, director clinical services, Ministry of Health, director research like me, then National Drug Authority, and then herbalists. And this council would be leveraged on by other authorities like KCCA, National Drug Authority. You find these agencies labor in vain to really put sanity because there is lack of a professional council. So we now have that act. And it's partly, there is also focus on validating the science, because there is the channel of validating scientifically is the only channel through which you can talk to the international world and really give due credibility to a herbal. I would also love to say that some people misunderstand herbs. Some say, for me, I don't touch those herbs. But by definition of WHO, even tea leaves are herbs, even coffee, even an onion, even a tomato. So when you say I don't touch herbs, then I don't expect to see you eating an onion. So we need to really get in there and see what is it. And WHO is there to guide. We have a country office here. So we can't just make a claim as a country, because even the WHO office will say, wait a minute, what are you saying? And you should have the science to talk for really what you're saying. Let me rest it there for the moment.
Thank you very much, Dr. Grace. Before you go, can you please talk about Covidex in detail? the demand for Covidex has shot through the roof. A lot of our participants have asked questions about this, and I'm going to go to your our participants. I'm going to go to your questions shortly. But yeah, please talk about Covidex. There's been controversy. The National Drug Authority, which you say you sit on their board, came out to say that the drug is not approved. There was also a statement recently from State House that the president didn't approve. Of course, the president shouldn't approve. It's not his mandate. Approve a drug. Where do we stand on Covidex? What should our participants go away with?
Thank you so much for that question. Fortunately, I know the proprietor very well, Dr. Wang. He was my staff member in Natural Chemotherapeutics. We are proud of him because he's our product actually, because from there he moved on and with his PhD, and he's leading a prestigious pharmabiotech, Marara, funded by the World Bank. And by all, you know, due diligence, he has published, he has put a product out of on the market with, you know, putting a product with a patent is not a small thing. So, but now this, the COVID pandemic, as you see, the wave 2, the way it's coming with variants that are really more efficient. Well, it can put somebody, probably people linked to the researcher, maybe to push something out there, because I have no reason to think that Dr. Wang wouldn't know the procedure. But the thing is that National Drug Authority, I'm part of it, and actually I sit on the Pharmacovigilance Committee. Of course, that product, if it had been submitted, it would come to our committee, but I must say it hasn't yet come in. Well, National Drug Authority did what it had to do, because otherwise it would be like it's a dog that doesn't. It came out to really say what it should do, gave highlights regarding how drug development is done. And I would also like to recap this, that when you're developing a herbal product, after you've picked it, maybe from the custodians of information, the traditional healers, you verify it through botany. We have an authentic reference point in the country that is with Makerere University Botany. You confirm the species you're using, then you go ahead to read literature, because most of these plants have been worked on. You want to pick out a method that would help you verify the information you've picked from the public. Then you take it through safety evaluation that we call pharmacology, testing on small animals. Research there, we call it phase 1. Then from there, the information, you get some preliminary information regarding toxicity, the dosage, then you go ahead to formulate. Now in Uganda, that process I've talked of may take just a month, and you should now, these days you have to take it through government analytical laboratories for them to do evaluation of microbiological contamination. Then you take to National Drug Authority, where you pay 10,000 for them to do their due diligence to confirm you've not picked anything from the pharmacy and put it there. Like of recent, we had about 40 formulations being passed on the market as libidos for men, only to find that they had been falsified with sildenafil. So NDA does its due diligence, and these days it has a state-of-the-art laboratory, and the whole lab is WHO pre-qualified. So that process alone, which may cover say 3 months, can get NDA give you approval in form of a notification to put your product on the market. They know it's there, so people keep using, but you should be gathering data regarding what it's doing to the people, and probably later, 3 years down the line, you could now file for registration. But of course, in the 3 years, you do clinical trials. So back to the issue of the product. I think Ogwang came out to admits that he hadn't probably taken it through there, but I think some people around got excited and probably got it, out there, but he quickly accepted. I think NDA called him, I wasn't there, but he accepted to go through the procedure because under COVID, an expedited procedure was put in place where all regulators come together, National Council, National Drug Authority, and Research Ethical Committee. And I've been taken through this experience because I'm principal investigator of a trial going on in Mulago, and we had to undergo that interface with we call it a joint review, and actually Ogwang was part of the joint review. It's like, of course, keep reporting to these groups, So the thing is that expedited process put in place means that procedures that used to take 5 years, 10 years now can take a month because of COVID. So that information is there. And I know Dr. Gwang knows it. And I'm giving it a doubt that somebody probably snatched it from him. That's what I have to say, because the Gwang I know, I wouldn't imagine. Because now, COVIDX, when you look at the ingredients in there, because the label has the ingredients, and one of them is popularly known to be very, very useful, the Wabugia Ugandans have talked about. But there is also another ingredient like me now in that docket, I know it very well. So the two plants put together definitely would do wonders. But there is no way a country would propagate that way, because like I've told you, since it has to be put in the nose, I'm close to some patients with COVID, and you have to remember their membranes, they are affected, highly inflamed. And if Wabugia is peppery a bit, I'm imagining putting Kamlali in the nose or something. So there is need for NDA to guide, do due diligence, and then give authorization. And that means the product can now go into pharmacies. So ladies and gentlemen, people have misunderstood government. Even people putting that the president is allowing this. The president is very much in touch with our group, the research we are doing. And he's very cautious about not going the Madagascan way. So the president, I don't know, but I think he really respects the science. He really respects, because if he didn't respect the science, right from March when we told him about what we are having, he would have said, please bring it. But there is a whole docket under Dr. Msenero guiding all the scientists. And actually, again, I must say, I sit on the steering committee of Ministry of Science, Technology and Innovation, and we do look at proposals put in, and I sit there on the steering committee to represent interest in natural products research. And Dr. Gwang has presented a proposal for funding, and he's been awarded funds. I don't know whether COVIDX is part of what is being researched on, but I would love to say that because of the anxiety, someone somewhere, because you use people in the lab, they formulate, maybe somebody ran away with the thought and that kind of thing, because he has come out to say, what is going to be done. Barra University has come out, they have a name to protect. So I really think this will be put right. And I believe NDA, for me, I sit on that committee. When that sample comes in, we shall do what it takes to ensure its due diligence is done, because I think it's a useful product. But it needs to come out like who shouldn't use, how should you use it? And if I'm using it and I'm using another component having the same Wabugia, what does it mean? Because Wabugia is a prescription plant. If you took overdose, trust me, you can have a heart bursting, and that's it. Thank you.
Thank you very much, Dr. Grace. Our participants, I'm now attending to your questions. I apologize in advance in case you don't hear your question or your name and you typed both. But we've tried to cluster all the questions in different groups, and we are going to direct them to the panelist you suggested. Again, if you don't hear your question, please, we apologize in advance, but we'll try and get anything in. So Dr. Grace, there's a bunch of questions for you here. I'll go through them. So if you can take a note, I'll ask them at once. And some of the things you've already talked about, but just for the benefit of our participants, please feel free to briefly recap in terms of responses around them. So we have One question, this is to you, Dr. Grace, from Marion Mbabazi. She asks, does steaming work? Does ginger and garlic work? Another question, what do you have to say about the use of marijuana tea or inhalation to prevent or treat COVID infection? The person also asked what you thought about the craze over usage of Covidex, but you've already responded to that. We have Ronnie who asks, what causes the positive negative sequence of results at testing within a short time? Another question for you, Dr. Grace. This is from Anita Nabatanzi. I personally know of individuals that have been critically unwell or down with COVID and have used the popular Covidex and got better in a day. Can you explain this or how other local solutions are working, e.g. the tobacco leaves? Are you aware of the possible side effects from these traditional solutions? Ideally, how long does it usually take in Uganda to do the trials for these traditional medicines and clear them for usage? Monica Mondo also asks, I want to know what herbals should we take to thin and remove the mucus in the lungs and those that improve the immunity. Marion Babazi again asks, does bombo, karitusi, avocado leaves work? In case you missed, you weren't able to note them in case I was reading very fast, please let me know. But if you can quickly just respond to these questions, Dr. Grace.
Thank you. I hope I'm clear because I'm on the road going to attend another meeting. Yeah, thank you, Marion. Does steaming work? Yes, steaming works in a sense that steam is at a higher temperature than boiling water. And this COVID virus, I think heat is one thing that can destroy it. So steam can really work in terms of destroying that virus where it is like on like in the nasal, you know, in the lining of the nose and the mouth. Though there are people who shouldn't go for steaming, people who
Hello, we are losing you. Your connection is
with patients should not be for garlic. Yes, it's in there. That are you hearing me now?
Yes, yes.
I've packed. Yes, ginger and garlic. People on this webinar, please go and read about these components which hail from India. You know, they are that useful because the components in there, a consortium of so many, you know, the medicinal components in there are well known, and these are entities that have volatile oils, and what you feel as a perfume, like when you boil ginger and you can feel that perfume, what you feel as perfume are small molecules. Most of them are small alcohols, and they are really very healing. Only that the dosage matters. You don't have to use too much, and the variety also matters. You hear people say, I want the indigenous Ntangawuzi, I want the foreign one. So those are varieties, but what we perceive as aroma, that we talk about aromatic medicine. Those are medicines, and they can really supplement the steam. Though if you don't have them, steam alone is also useful. When we come to somebody taking Covidex and getting better, I'm not surprised because the ingredients in there are highly medicinal, and actually they have antiviral properties, only that there is need for moderation, optimization, you know, the dosage in different formulation forms. For example, for us in Wandegea, we've made Wabugia ugandensis syrup, funded by government. And when people take the syrup, I think we're gathering data. They really find it's quite useful in various ways. We are yet to really, it's under notification by NDA. It's a syrup in a molasses base. Molasses are a bit sweet. So for those who cannot use Wabugia in a sugar base, can benefit from Covidex because Wabugia there is not in a sugar base. But I wouldn't want to say that as part of NDA because until it's notified. I would like to see Covidex notified so that people can be referred to in pharmacies to really get it. So getting better, like the doctors presented, it depends on, are you in a mild condition? Are you, for people, for COVID patients that are, in that critical condition, things may be different, but mild and, it all depends on the level. Yeah, so tobacco leaves and other related plants, you can even talk of marijuana. These ones, when you do search, marijuana has already been validated for COVID, but the validation has been through a clinical trial, which should be repeated. Like here, if we want to use it, we should have the clinical trial repeated here. And there is a plan for that, to try it here in a Ugandan setting, to really see whether people who at the moment have been allowed to grow these plants in some parts of the country, whether we could tap a little bit for medical purposes. But that one is being handled by, it was last handled by last cabinet, and we anticipate that the new cabinet this time round will pick it up, because nobody should touch cannabis, not even a researcher, unless authorized by the Minister of Health. So we are just waiting, but we know that it's been validated for COVID, and in European countries, maybe people are benefiting already. And that's why we're seeing Europeans coming here to get licenses to grow their variety here because of our organic soils. And yeah, so, the fact that it's working still doesn't give us that audacity to pick, to use those unauthorized plants, because we have other issues to look at, like our youth misusing these things, and then we're getting into issues. But when I particularly emphasize for marijuana has varieties, and the one that can have medical use, unfortunately, you may not easily differentiate it from the other bad one. So we need strict regulations that will ensure that as the country gets in there, all dockets are mentored, the prescribers, the pharmacists, the legal framework, but it's already in the offing under Prime Minister's office as of the last cabinet, and currently the current Prime Minister has been Minister in Health. So I believe that there is hope that this will move fast. Then the issue of, talked of a bombo, do they work or whatever? For any herb, for you to ask, does it work? You have to go in the laboratory and ascertain. So it's the scientific process, which hasn't always been funded, but now with the funding, we hope to take through these processes. But I want to let you know that taking through one product, the minimum is 3 billion Uganda shillings. So you don't expect things to move very, very fast, but the notification where NDA does due diligence, we can use that channel and get so many products on the market while they are picking data to warrant going through a clinical trial that is that expensive. And remember, funders don't fund such things. These have to be country initiatives. So we must hail our government at the moment to really, that emotional intelligence, Dr. Sabrina talked about it. We need it in all dockets. Yeah, because if borders are closed and you have to really, you can't even fly out, and you're a country like Uganda with rich biodiversity, and you're having forests disappearing, there is need to mentor people in emotional intelligence and in all dockets so that we can get what really want. Thank you.
Thank you very much, Dr. Grace. I'm going now to read out a bunch of questions for you, Dr. Sabrina Kitaka. Please note them down and respond to them at once. Hopefully you can do that in less than 10 minutes, because we are running out of time and we have a lot of questions. So the first participant thanks you and would like you to expound on the COVID effects, post-COVID effects. The second question is when to consult a physician. When should a person consult a physician? And how can one manage these symptoms, especially chest pains and heaviness? Dan Katumba would like you to expound on the timing of testing and the incubation period. After being in contact, when is the best time to test and probably start medication? Daniel would like to know, apparently he's had someone collapsing shortly after feeling difficulty in breathing. How easy is it to know that one is sick? Should we get oximeters at least, he asks. Another participant would like you to comment on the differing recommended ages for masking in children. Some information, he says some information recommend ages above 6 years. Please advise. Another question, how long should one steam? What should be added to the steam solution? This one also goes to you, Dr. Sabrina. Paul Jesse, another participant, asks, as the technocrats, do you feel that government has given COVID the attention it deserves in terms of support? What can government do better? Another question for you, would Dr. Sabrina please restate how to manage the home environment when a member of the family, particularly children, are sick? What amenities can and should not be shared? Sandra N also asks, Dr. Sabrina, is it still healthy for mothers to continue breastfeeding a kid between 1 and 2 years and a half in this pandemic? The last question, is it okay for my son, who is 15 years old, who had an open heart surgery 3 months ago, where his 2 mitral valves were placed on a warfarin for life, to get the COVID-19 vaccine? Those are the questions for you, Dr. Sabrina. Please do your best to try and respond to them as quickly as possible. Thank you.
Thank you very much for those questions. I had actually tried to answer to the individuals in the chat room, but I'm going to do my best to answer the questions. But before I do that, I'd like to correct Dr. Kabbale, who said that azithromycin is not useful as treatment for COVID-19. This is from a systematic review from the Lancet, where they say that azithromycin can actually increase the pH of the Golgi network in the virus protein wall. It can also reduce the level of the enzyme furin, and this can interfere with the proliferation of SARS-CoV-2. There's also an ability of azithromycin to reduce on the levels of the pro-inflammatory cytokines. So COVID-19 can actually be treated with azithromycin, but we need to be careful not to use it as prophylaxis, because we know that the next pandemic is resistant bacteria, which will form. So now back to the questions. There are people called long haulers or post-COVID complicated patients. And you know that COVID-19 can damage all the organs. It can damage the kidneys. It can develop coronary heart disease. It can damage the pancreas. So indeed, when we say that 76,000 cases are in Uganda confirmed, but only 46,000 have cured completely, it means that about 25,000 people are still suffering with long COVID complications, including neurological deficit. So these people are being followed up at the Lung Institute at Makerere University and also at Mulago Hospital. So when should you consult a physician? I think you should consult a physician if you're worried. The patient is the one who complains. And if you're complaining, please consult a physician. Chest pain can be caused by various things. It can be caused because someone is coughing a lot and their diaphragm is hurting. It can be caused because the patient has developed a pulmonary embolus. And we know that microemboli and even larger clots can form when a patient has COVID-19. So how do you manage? If the pain is mild, you can take paracetamol, but if the pain is intense, please consult a physician so that you're able to be seen in a high-functioning institution. The timing of testing and the incubation period. So when you get into contact with a person who has COVID-19, that is your day 0. And if the person has, spat in your face, exchange saliva, etc., within 2 days, you can actually test positive. The average period is about 7 days, but some people prolong the incubation period to about 14 days. So if you have symptoms, you're better off going to test. I saw in the questions, somebody asking that, can you get reinfected after you've got your bout of COVID? Yes, you can. And there's a recent paper that was discussed about a 76-year-old man in the United Kingdom who was tested positive 43 different times. Eventually, he had to be put on a battery of multiple antiviral drugs, and now he's completely cured. So there are people who are long holders of COVID-19. They are not even carriers, they continuously suffer from the COVID-19. Patient collapses and they have COVID. That could be because they are one of those people we call happy hypoxics. They are laughing and smiling, but their oxygen saturation is extremely low. Now we need to understand that COVID-19 may cause mucus secretions like the one Dr. Kabbale talked about, but also we know that COVID-19 can also cause microthrombi in the lungs and prevent oxygen exchange, and the person can be extremely hypoxic. Now, when we talk about hypoxia, we mean that the level of saturation of oxygen is less than 90. When a patient's oxygen saturates below 90, their bodies start to demand for more oxygen and they start to breathe very fast and they have air hunger. So a patient who collapses may collapse because they have a low oxygen tension, but also because they could have had a cardiac arrest. It's important for people to acquire oxygen pulse oximeters in their houses. But I have an experience. Last year around October, I was in contact with someone who had COVID-19 and I was very anxious. I bought a small pulse oximeter, and when I tested my pulse ox, it kept dropping from 98 to 94 to 90. I became extremely alarmed and even called for an ambulance. By the time I reached Mulago Hospital, my colleague was really scared and thought I really had COVID, what. They checked my pulse oximeter again using a different model and I was saturating at 98. So my family decided to take me back home and, well, I survived getting into the HDU. So how do we differentiate recommendations? Now, the recommendation for a mask in the United States, supported by the American Academy of Pediatrics, of whom I'm an international member, recommends that children above the age of 2 years can wear a mask, a cloth mask. In Uganda, the Ministry of Health chose 6 years. But I think this is a place where people use guidelines differently. A child in America may have better cognition, better supervision, whereas that may not necessarily be the case here in Uganda. So for Uganda, we are saying 6 years, but in the CDC guidelines, the American Academy of Pediatrics, it's 2 years. But you have to supervise very carefully any child who is wearing a mask, because they don't know how to coordinate. They could keep on the mask for a very long time and end up with headaches, dehydration. They are not eating, they're just stuck there with their mask. How long should I steam? When I steam, personally, I steam for other health reasons, to open the pores on my face. And I usually steam for 5 to 10 minutes. For people who steam because they have nasal congestion, I would recommend that they steam for at least 5 to 10 minutes. But please understand, steaming is not treatment for COVID-19. Steaming just alleviates symptoms like the nasal congestion. It gives you a nice feeling. If you include chamomile or eucalyptus, something that smells nice and gives you a good feel to reduce your anxiety, I think that it's okay. But at no one point should you pick maybe a 3-month-old baby and stick them in the same environment where you're steaming, because steaming can actually hurt the mucous membranes and cause burns. So we just have to be careful. Too much of anything is always bad. I think that government has tried to do a lot. They have developed guidelines. They've provided public health and social enterprise guidelines. But the truth is, our health system is currently overstretched. I've seen videos of people fighting for oxygen cylinders. I have seen and heard of patients who have been bounced from many hospitals. And personally, I have lost colleagues, doctors, who have died because of lack of access to a health facility. So we need to do more, but we all need to do more together. We are all the government. When you have a sick child in your house, just know potentially all of you could become infected. So this is the time to up your game on standard operating procedures. Wear a mask, wash your hands, clean down the surfaces, and you don't necessarily have to use sanitizer for cleaning the surfaces. You can use soap, you can dilute Jik and clean down the surfaces. Breastfeeding, I know we are encouraging breastfeeding, and I breastfed my last born until he was 2.5 years. But in this time with COVID-19, if a mother has a baby of 2.5 years and they're able to feed on other things, breast milk is not the only food that this child can eat. I think you can withhold the breast milk. But for babies below the age of 6 months, I think it's very critical that the mother continues to breastfeed that baby and wear a mask when she is breastfeeding. Sorry about your son who has had to undergo open heart surgery, and he is on warfarin. Warfarin is an anticoagulant. It becomes a bit dicey whether to recommend COVID-19 vaccine, but you have to understand that this child is also at risk of getting infected, and because he's 15, you would want to wait for a vaccine that has been recommended for children below the age of 18. And currently in the world, the vaccines that have been recommended for children below the age of 18 are Pfizer-BioNTech, and very soon Moderna will be also recommended. Thank you.
Thank you very much, Dr. Sabrina, for your responses. Now coming to you, Arnold, I have 1 million questions for you, and I have exactly 6 minutes for you to respond to them. So Do the magic, please. Straight to the questions. Why are people still dying after getting fully vaccinated? And if you think you've responded to some of these questions, or can go to the chat, out to the Q&A and respond to them there as someone else talks, please do that. Respond to those that you feel are very significant. We apologize to our participants. In case you haven't had your question, please, it's because we had a short time within which to discuss a lot of things. So the other question is, do you think the impotence issues in men could be caused by psychological issues? It's a very serious question. Marion Mbabasi, is it good for mothers with 3 months babies to get vaccinated? Sylvia Nankebe, can I go for vaccination if I have tested positive and I'm on medication, or I have to wait and have negative test results? JK Musamba, if someone gets vaccinated during the incubation period of the virus, will they be adversely affected? Should people first test before vaccinating? Nabitaka Barbara, thank you very much for the webinar. I have a question. Is 16 too young to get the vaccine? Joseph SK, when is one supposed to get the second jab after contracting COVID? Midway after the first jab? Another question, we are hearing about the spike protein in the vaccine and how it's causing problems in the body. Arnold, the last one is from Charlotte Ntulume. Arnold, please comment on the effectiveness of chloroquine and ivermectin as treatment of COVID-19. Why have big pharma fought these drugs so hard, even when there's evidence that they are effective? There's also reported censorship by major medical journals of publication of research findings on these drugs' effectiveness as COVID-19 treatment. Do you think there are some hidden agenda? And yeah, you feel free to briefly respond to Dr. Sabrina about Amox. One last one, if you're still taking the notes, is from Chris Mafumbo. Chris Mafumbo would like to know whether the possibility of developing an infectious drug using ethnomedicine and targeted therapy. I noticed that we now even have, we have 5 minutes left. So please use to respond to any of the questions, and we'll have one of the members of the committee of the association close the webinar. Thank you very much, Arnold.
Okay, thank you very much. My camera has been turned off, so I cannot turn on myself. But maybe in 1 minute, I just want to share something. So in terms of azithromycin, so this is a paper from the Lancet, the principal trial, and we won't read all of it, but once what you look at I don't know if you can see my screen. Hello?
Yes, we can see the screen.
Okay. Yes, so if you just look here at the interpretation, what I have highlighted in red, it says our findings do not justify the routine use of azithromycin for reducing time to recovery or risk of hospitalization for people suspected of COVID-19 in the community. So this is the principal trial. It looked at the number of people studied there. You can see them. This is for prevention. Yes, it does not recommend it. Then this is the recovery study group, still looking at azithromycin in patients admitted to hospital with COVID-19. In the interpretation, it says in patients admitted to hospital with COVID-19, azithromycin did not improve survival or pre-specified clinical outcomes. Azithromycin use in patients in hospitals with COVID-19 should be restricted to patients in whom there is a clear antimicrobial infection. So the Lancet journal is one of the most highly recommended journals, and it's extremely difficult to publish a paper in. So that addresses the issue of azithromycin. Quickly going over to steaming. Again, this is
one,
the
Arnold.
Yes.
A quick one, Arnold. Yeah,
yes.
Please use a few more minutes. I understand from our technical people that we are going to go on for at least 10 more minutes after the time we are supposed to close. So use another 5, and then we should be our participants shouldn't log off. We will have an extra 10 minutes to go through the questions that you're dealing with.
Okay, thank you very much.
Use 5 of those, Arnold. Thank you very much.
No, I will be as quick as possible. But as you can see from these 2 studies in the Lancet, actually they are saying they are saying that azithromycin does not add value in both patients in the community and patients who are hospitalized with severe disease. This is also from the Lancet, and it's about steam inhalation and pediatric bans during the COVID-19 pandemic. Just in this particular section, they are saying that it is actually hazardous. And I want us to just think about this. Our lungs, for air to pass through the lining of our alveoli, the airbags, what we used to call them in high school, the lining is very, very thin. It is very, very delicate to allow air to be able to pass through. It is not developed for high temperatures. So if you had 100 degrees of hot water pouring on your arm, where there is reinforced skin with heavy keratin, you scream. Imagine what would happen if 100 degrees of temperature of steam got into contact with your lungs. So these people actually are showing that steam does not treat COVID. It is actually a risk because it can cause further damage and inflammation on your lungs. However, Dr. Grace is right that steam can be used as a vehicle to prepare some aromatic oils or essential oils that might offer benefit in the lungs. So that's just about the inhalation and the azithromycin. Now, running very quickly to the questions, I'll start with the most recent. Can one develop an infectious drug using ethnomedicine? Yes, many drugs have been developed from herbs, including the anti-malarial drugs that we use, the Coartem or artemisinin from Artemisia annua. So it is possible. Comment on the effectiveness of chloroquine and ivermectin. So there are numerous papers that show that both chloroquine and ivermectin do not work. Do Big Pharma have a Big Pharma fighting against new drugs? The truth is no. The people who published evidence that dexamethasone works at the University of Oxford, who are also the makers of the AstraZeneca vaccine. If they were in it for the money, they wouldn't have published about dexamethasone because it's extremely cheap. It's probably cheaper than the paracetamol you buy. So there is no hidden agenda. The only thing is that papers and journals do not want to publish garbage, sorry to say. They want to publish reputable information that meets the basic standards for clinical trials. Hearing about the spike protein and how does it cause problems. So on the virus, there's those small protruding things that you see in pictures everywhere. Those are called the spike proteins. And they're the ones that the pathogen, that the virus uses to attach to our human cells. In the more infectious variant of COVID-19, the Delta variant, these spike proteins seem to be more aggressive in terms of attaching to our cells, and replication can only occur when they have attached. So the mutation seems to have made them attach more to our S2 receptors. But also in some, like the Uganda one, perhaps the spike protein is not as active. When is one supposed to get the second jab after getting COVID-19? Preferably, I've seen literature saying 10 days to 2 weeks after you stop being symptomatic. But if you have money, you can do a test to confirm. I don't think it does you any harm to test. is 16 too young to get the vaccine? So it depends. When you look at the clinical trials, the AstraZeneca vaccine was done in people aged 18 to 65 years of age. So they didn't have data on people below 18, whereas the Pfizer study actually included people 16 years and above. So for the Pfizer study, there is evidence that it is safe. I genuinely think that for the AstraZeneca vaccine, it will also be safe, but we do not have data on that. Just a second, let me see where I am. Can someone get vaccinated during incubation? Will they be affected? So it seems that there are some people who get severely sick after vaccination, yes? And it is most likely that these people already had a latent infection that was just exacerbated by immunization. So I think maybe a clinician would be better positioned to answer that, but I think it is good for you to maintain SOPs to make sure that by the time you go for immunization, you do not have any risk of infection. Is it good for mothers with 3-month-old babies to get vaccinated? So I believe antibodies can be transferred from the mother to the baby, so it might actually offer a protective effect to the baby. Do I think impotence issues in men could be psychological? I do not know. I have not found literature on this. Why are people still dying after getting fully vaccinated? I think I have sort of answered this. Some of the people probably had a latent infection that just got triggered after immunization. But again, in science, there is nothing like 100%, So even the statistics that I showed you where they say it is 100% effective in averting death, it's more or less 99.9999. Yes, thank you very much. I think that answers all the questions.
It's concluding.
Hello, thank you very much, Arnold. I once again apologize to your participants whose questions have not been mentioned here and responded to. As we try to wrap up, our panelists, if you find a burning question in the Q&A section, please respond to it. Otherwise, I'm going to ask Dr. Sabrina to represent all our panelists in making concluding remarks. After that, we will have Jackie Kaija, the treasurer of the Chevening Alumni Association of Uganda. Dr. Sabrina, please.
Is it possible to show my video?
Yes, I think if you share your screen, I think it should be. But we have very limited time. I don't know if.
Okay.
Yeah.
All right. So I just wanted to see the people I'm talking to and to say congratulations. Congratulations to the Chevening Alumni Association. Sincere thanks to the president, Helen Kawesa, who is my dear friend. Congratulations. For me as a panelist, I feel really privileged and to have sat on the same panel as Dr. Kabbale, who was even one of the participants of the
Hello?
Who was one of the participants of the Oxford.
Sorry, Dr. Sabrina. Someone amongst the participants, your audio is on and there's background noise. And it's affecting please put yourself on mute. Thank you. Dr. Sabrina, you can go ahead. Sorry about the interruption.
That's okay. I said I was privileged to be on the same panel as Dr. Kabbale, who was actually a participant of the Oxford AstraZeneca clinical trial. We are very proud of you and your work. I was also privileged to be on the same panel as Dr. Grace Nambatya, who I hold in high regard. She has promoted traditional medicine and has laid efforts to ensure that the traditional medicine, when it comes out into the public, is of quality measure. To all the participants who asked questions, your questions were amazing, but let us continue this discussion. And to you, Haggai, thank you for being a great moderator. We truly appreciate your insights and your capacity to moderate this webinar. Let us all stay safe and let us ensure that we do each of our parts to the best of our ability so that we can fight this pandemic. Thank you so much.
Thank you very much, our lovely panelists and our participants for attending this webinar. It's been Haggai Matsiko as the moderator. We had Dr. Sabrina Kitaka amongst the panelists. We had Dr. Kabbale, and we also had Dr. Grace. We're now going to invite Jackie Kaija, the treasurer of the Chevening Alumni Association, to come and give closing remarks. Thank you once again for attending this webinar.
Good morning, ladies and gentlemen. My name is Jacqueline Kaija, and I'm the treasurer of the Chevening Alumni Association of Uganda. I'd like to take this opportunity to thank very sincerely Dr. Grace, Nambatya Kyeyune, Dr. Sabrina Kitaka, Arnold Kabbale, for being such a great team this morning, for taking of your time, your experience and your knowledge and sharing in such an amazing way. Thank you so much. I'd also like to take this opportunity to thank Haggai Matsiko. Thank you so much for being a great moderator this morning. Special thanks to the Ministry of Energy for the Zoom facility. Thank you so much to the organizing committee that put this webinar together. I'd also like to thank all our participants for your participation, for the great questions, and for also taking the time to be a part of this discussion, because it made it that much richer. So our next webinar series is going to be next month. Topics are welcome as suggestions for what we can discuss next. I'll also take this opportunity to remind our alumni members to pay up your subscription and membership fees. We have avenues in which you can pay up your fees, and these avenues and amounts will be communicated on our different platforms. Thank you very much and have a wonderful day. Bye.
Bye.
Bye. Thank you. Bye, and thank you for coming and making it. It was very rich. We are honored and indebted. Thank you. Bye.
Thank you, everyone. Have a good weekend.
And to you.
Bye.
Bye.
Thank you. Thank you so much, speakers. Thank you all participants. Panelists, you may, okay, Alan, I see your message, but I think.
Have some people left already, the panelists?
Yeah, I think so.
Yes, they already have. We can take it to the group possibly.
Okay, let's take it to the group then.
Okay, thank you.
Why I wanted some panelists is because there are so many questions and I was thinking, how do we follow up answering them?
We could get in touch with the speakers directly. At least we have them. We have them in touch. Yeah.
That's fine. I think let's refer to the WhatsApp chat then.
Brilliant.
Thanks.
Oh well.
Thank you all.
Thank you all.
Bye.